Testing. Testing. Welcome everyone to the Prostate Cafe, our monthly meeting here at the Dattoli Cancer Center. I wanted to first tell you, I noticed there's only decaf coffee, and that's interesting because apparently Jade, who makes these arrangements, thought that coffee with caffeine is bad for you, and it's not. It's actually really healthy. Okay, it's one of the healthiest things we know of now. It's great for cognitive function, it's great for liver, it's great for kidneys, and it's great for bone strength. So it's got a lot of pluses associated with it. On the other hand, when you're under treatment here, it may act as a bladder irritant. So that's the reason why we discourage it primarily during treatment. And even then, I do tell patients, though, you could try it. It may not hurt you at all, or it may make you have like increased frequency of urination. Can everyone hear me? Okay. So our breakfast is sponsored by the Dendrion Company. We've been working with them for about 18 months now. It's very interesting. It's for select patients, but what we do with this company is use their product called Provenge. And what it does is very interesting. And we take blood from you. Okay, so it's kind of like a bloodletting. We call it leukapheresis in medicine. And that is then sent to a specialty lab in Atlanta where they kind of tune up your own body's immune system based on the special blood cells that they removed from the bloodletting, which are primarily PAP cells, and then send them back kind of charged up. So it's an individualized, tailored type of treatment for prostate cancer, and we're seeing some really nice results with very, very little, if any, side effects. So anyhow, with respect to the Prostate Cafe, as we say, you bring the questions, and we'll bring the breakfast. Are there any burning questions at this time? Otherwise, I'll just talk. Okay, so there's some interesting topics that we can touch upon since we've already touched upon coffee and cancer and diet. Prostate cancer is a little special, but so are other cancers as it pertains to diet. From the general perspective, we look around and we say, what things would be the most damaging for cancer? What things would encourage cancer to grow from the get-go, and what items would cause cancer to progress? And two major items that are bad, and that would be red meat and pork. And they're very high in saturated fats, and we don't like saturated fats in cancer medicine. So those would be the main events. And then when we look around the globe, we find that people living the longest, and they live in these places called blue zones. They primarily abide by a diet which is heavy in fruits and vegetables. And when they do get their meat, they primarily get their meat from fish, which is then a pescatarian diet, or fish and poultry. And we generally categorize that as the Mediterranean diet. And again, it's all over. You can Google it up and see exactly what is recommended. But again, red meat and pork are not good things for cancer, and they're definitely not good things for prostate cancer. There have been some studies on prostate cancer most specifically, and looked at other things that might be causal, namely it causes prostate cancer from the beginning. And dairy keeps coming up for prostate cancer. So, I know we do have today so many milk alternatives, and those are probably wise, oat milk, almond milk, soy milk. There have been exceptions within the respect of dairy, and that would be cheeses. For example, goat's cheese, sheep's cheese appear to be good. And again, those are the cheeses that most of the people living in the blue zones and who abide by the Mediterranean diet do ingest. There's a specific supplement. It's called lycopene. And lycopene is what we find in cooked tomatoes. Now, it is in fresh tomatoes, but in cooked tomatoes especially so. and it's very high in that lycopene, which has specific effect of prostate cancer. So that's one that is prostate cancer specific. It's also found in watermelon. It's also found in red grapes, and it's found in red beets. So those are healthy things to consider and do. Other things that appear to be very nutritious would be avocados, perhaps the most nutritious food we know of. And the common adage, an apple a day keeps the doctor away. Now we're moving towards an avocado a day keeps the doctor away. So that seems to be important. The other one that seems to be important with respect to prevention of cancers in the first place, and that's extra virgin olive oil. You just can't get enough of it. And inflammation tends to be the root cause of all diseases. So when you look around, you're going to find heart disease. What feeds it? Pretty similar to the cancer diet, namely red meat and pork, two most onerous things for the heart. Okay, and those of you who eat a lot of meat, I'm not saying to cut it out entirely, but to lessen, in moderation, the consumption of red meat and pork. But inflammation is a really big deal for almost every disease, including diabetes, but especially heart disease and cancer. So those are some good things. We do recommend vitamins and supplements. So those of you who've been diagnosed as having prostate cancer, a couple things you want to do, and one is boost your immune system. So there's three major vitamins that do that, and that would be primarily vitamin D3. It's interesting because a long time ago, about 18 years ago, was first identified that vitamin D3 is linked to prostate cancer, and that was very clear. And we had never heard of that before, but about 18 years ago, what I did is I had all my patients, both new patients and patients in follow-up, and we have thousands of those, and subject them all to vitamin D3 panels to find that a sizable number of them had vitamin D3 deficiency, and they were very low compared to other patients, for example, in the waiting room or elsewhere, who had colon cancer, lung cancer. Their D3s weren't nearly as low as the patients having prostate cancer, and in fact, in many of them, it took some to get their D3s to normal levels. It's almost like a resistance. So D3 is something that you can get from sunlight. We live here in Florida. You can get a lot of it here. But in many cases, you should also probably supplementing that with a supplemental D3 pill, especially those who have prostate cancer. The other two that tend to be important is zinc. And again, I'd say you can't get enough, but you can overdose on zinc. Probably 100 milligrams a day is a good number. Even 50 is fine. Up to 200 seems to be very safe. So zinc is important. Vitamin C, we've all heard about vitamin C, and there's no question about it. It has antioxidant properties, but it also helps to boost the immune system. And with cancers, that's what it's all about. It seems that when we get cancers, it's because our immune surveillance system failed us, and we need to boost that immune system. So getting a cancer is right away telling you, my immune system failed me, what can I do? And those would be the three major vitamins for immune surveillance. But there are many others which tend to be beneficial for patients having cancer, patients undergoing radiation and hormonal therapy as well. As you probably know here, we're not big fans of chemotherapy. It's kind of falling, I think, away from whenever we can with cancer medicine. Chemotherapy does drop your immune system, whereas hormonal therapy upregulates or strengthens your immune system. Similarly, so does radiation. But there are other things that we can do to boost our immune systems and get our immune surveillance systems working better. And those come primarily with antioxidants and anti-inflammatories. And most antioxidants are also anti-inflammatory. So, for example, turmeric, very powerful antioxidant and anti-inflammatory agent. So we recommend that. It also comes in another similar form called curcumin. So curcumin, turmeric, great for the immune system, great for being anti-inflammatory as well as antioxidant. The other one is resveratrol. Resveratrol is what we get primarily from red grapes, and it can be in red wine. And it's a powerful antioxidant and an anti-inflammatory agent. Those two are probably should be in all of our regimens, but we could eat a lot of grapes, and I suppose you could drink a lot of wine. The problem is to get enough wine, if you get enough resveratrol, you'd have to be a wino, is the bottom line. So we don't recommend that. But again, alcohol comes and goes too with the literature. Is it good? Is it bad? Probably small amounts, moderation seems to be okay. And if you did get it primarily from wine, wines tends to be better than the hard liquors. So those are good. We have others which are more specific to our patients. And there is actually one vitamin that we sell here. And in the back of the room, there's a lineup of our vitamins and supplements. I did that because a long time ago, I take a lot of vitamins and supplements myself. And a long time ago, though, I did an analysis of vitamins and supplements using a third party and found that the vast majority of vitamins and supplements out there that you could buy on Amazon or wherever you do get them, or in CVS or Walgreens, does not have what they're purported to have in them. And so I try to find out how do we figure it out? How do we get all those vitamins and supplements that the bottle states? The FDA doesn't even have to approve of a vitamin and supplement until it's been released. And then some part of that drugs or that supplement or vitamins life, the FDA may come in and then say, oh, no, this is no good. But that's what happens. So there's many out there that are not even FDA approved. But the bottom line is, when we did a third-party analysis, we found that most did not contain what they said on the bottle label, the ingredients, yet most had many other additives that are even bad for you, that could actually be potentially carcinogenic. So based on that and the fact that I was taking so many vitamins, I started making them for myself. And what we do here is have very strict guidelines for our vitamins. And what that means is that they have to pass certain institutional standards, one of which is NSF. And that's a very strict one, which basically says, what is on this label is exactly what's in it and by percentage. And that's important. The other one that's important is USP. It's another third-party grading system, and every single vitamin that has those has to be up to snuff in terms of exactly what it says on the bottle. And there's another one called GMP, and that's also the facility itself. And if they follow GMP guidelines, it makes that facility that much more strict. So anyhow, those are the things we like to see in vitamins and supplements. When you go home, if you're taking vitamin supplements, check on your bottle, see if it says things like NSF, USP, GMP. Those are the most important ones. And again, the ones that we have or we sell here at Dattoli Cancer Center do meet those strict criteria. So that's good. Fish oil is also very interesting because fish oil, I told you with the diet, pescatarian diet, very healthy. And but fish oil itself is also good as a supplement. We know that it's good for cognitive function, prevention of Alzheimer's and dementia. It's also good for the heart. It does thin your blood. But the fact is that most people don't know it, and that is when you have a bottle of fish oil and you open it up, it's got to go in the refrigerator. Otherwise, it becomes pretty much nasty. It loses all its important properties. Doesn't make you ill, but it's just not good anymore. It's been oxidized. So that is also another antioxidant. As I say, most anti-inflammatories are also antioxidant agents. And so that's what most of you will find that we sell here, because those are the important properties that we look to have. Anyhow, I think that pretty much sums it up from a dietary perspective. And again, as I say, what's good for, or let me say what's bad for cancer, that is everything I just mentioned, cancers don't like it. So you should be doing those. Also helps with the cardiac system, with your heart. And so it lessens risks of all kinds with the heart, because again, all diseases are based on inflammation, but especially cardiac diseases and cancer. So Does anyone have any questions at this time? Yes, sir.
How about sugar? How bad is sugar for you?
So here's the deal with prostate cancer, okay? Sugar is bad from the standpoint of virtually every other cancer. Excuse me. Turn this off. So, in fact, when a person is diagnosed as having cancer, we do these tests called PET scans. And with respect to virtually every cancer out there, with the exception of two, and that's prostate cancer and kidney cancers, what you do is you inject sugar, okay? And what happens is the sugar finds the cancer because the cancer is hungry for sugar. And that particular PET scan then looks at activities throughout your body, and it may look at a spot, that's right at a woman's breast or in a lymph node or in a bone, because it's showing where the cancer is, because the cancer likes sugar. Not for the prostate, though. So with prostate cancer, we don't use a sugar molecule to image for prostate cancer spread. We use other molecules, and right now we're using one called PSMA, which is a prostate-specific molecule which targets where prostate cancer is located. Now, having said that, there is another pathway. So that's for imaging. But if we're more concerned about the cancer, in and of itself, then sugar is not good. Because sugar, if it's not completely burned out of your body by exercising and walking and all the things that we do, it does hang around and it acts as a inflammation it catapults it to a level of inflammation, but it goes through a process. So it's not directly bad for prostate cancer, but it is in a roundabout way. So we're never really recommending sugar for patients with cancer, nor with prostate cancer or kidney cancer. But it's probably not as bad taking a little bit of sweet as it would if you had a lung cancer, a pancreatic cancer, a colorectal cancer, all those other cancers which directly feed on the cancer. But prostate does have a backdoor way that the sugar could get to it in a bad way. So that's pretty much it as it pertains to sugars. All right.
Thank you.
Welcome. Yes.
What are common mistakes people make after getting treated that could hurt their long-term result or cause relapse?
So as Jade's asking is, patient who's been treated here, what can you go out there and do that's all bad for you in terms of, fostering a relapse of the prostate cancer? Well, many that I just mentioned. So if you go out there and start eating all the bad foods, and that includes the processed foods, the ultra processed foods, they're really bad too. And I should have mentioned those earlier, but you want to stay away from all those things, what we call junk. So junk foods are bad. Foods which are high in saturated fats are bad. The other things that we're concerned about, and there's a particular push among both men and women, but especially men, to supplant the body's levels of testosterone to higher levels. And I see this going on, and doctors are doing it. And in fact, doctors are making a business out of just giving testosterone. They typically do it with injections. It's typically done on a monthly basis. And guess what? Yeah, it's a chargeable, billable item. So you have now internal medicine doctors doing it. You have urologists doing it. And that's really bad because testosterone, as many of you do know, feeds prostate cancer. Okay. And that's a direct link right there. Testosterone feeds prostate cancer. Now, if you happen to be cured of your treatment, normal levels of testosterone are not going to bother the cancer. It's just not. And so, I always look at someone's testosterone. What I'm finding more and more is even men with fairly good testosterone levels, something like between 350 and 550 or 600, even they are being told by their doctors that they can do better, if you get testosterone. What man at age 60 to 80 or 85 is not experiencing some level of fatigue? but now your internal medicine doctor, your urologist saying, oh yeah, we can boost your energy levels by giving you testosterone. It'll do absolutely nothing because you already have a baseline testosterone. That's good. Now, there are men who have low testosterones, and that's typically before treatment. Certainly before treatment here with hormones, hormones do take away the testosterone temporarily. But the fact of the matter is we don't want to be giving testosterone surges to your body after you're off the hormones, unless your body never recovers and the testosterone stays really low. And that would be a patient whose testosterones are in the teens to 150 or something like that. That's concerning. And maybe in those patients, we should be doing something with testosterone replacement. What we do here, though, is try to be safe about that, too, when we're giving testosterone replacement, knowing that it's those bursts of testosterone that cause problems. And you get these spikes when you get testosterone injections. And that's probably the causal event that may have spawned on your cancer to grow again, because it's getting spikes after you've been treated. So what we try to do here is not give the spikes, but instead use it in a slow, progressive way where the testosterone more or less plateaus in your system. And the way we found that's very safe doing that would be by lotions and creams that also bring on testosterone in a higher way, but not with peaks or spikes, but which also have troughs. We also think, for example, what causes prostate cancer in the first place? Well, in many cases, it's a genetic phenomenon, and it's your genes that cause it. And it may be you have a familial tendency to develop prostate cancer. However, we do know that men who are in their adolescence and 20s who have these bounding testosterones are also at higher prevalence of developing prostate cancer. So testosterone is not necessarily a good thing unless it's very low. So those would be the major things that have our attention now. Also, testosterone left to its own accord breaks down to a molecule that we call dihydrotestosterone. So when you have testosterone, which we call T, left to its own accord, it's going to break down to something called DHT. Interestingly, DHT is 10 to 20 times as powerful stimulating prostate cancer as is the testosterone. So around here, many of you will know that we commonly use agents which stop the DHT. And those agents are things like Avodart, also called dutasteride, Proscar, also called finasteride. They're very safe. They don't have a lot of side effects. In fact, they're also known for growing hair. So those who've heard about alopecia, for example, in men, male balding, they use these agents to grow hair. Well, we use them to offset the DHT. And what we try to do is not use it forever in most patients, but use it for a period of time when we're really, really wanting not to have any stimulation of prostate cancer at all. And so if we can keep the DHT away, a very powerful stimulant, that's a big plus. There's another side note to that, and that is if testosterone is not being converted to DHT, you end up having more T, which could be good in the long run, But anyhow, we use it for a certain period of time, not forever. There's some other things that stimulate prostate cancer as well, and those of you may have heard about a drug that we use here called cabergoline. And cabergoline inhibits a molecule that comes out of the pituitary of the brain. It's called prolactin. Prolactin is very powerful, stimulating prostate cancer, similar to DHT. Meanwhile, taking away the prolactin really doesn't have any adverse effects. In fact, if you review the literature on prolactin in men, okay, what happens is as we get older, our prolactin levels go up. And so it stands to reason that it could be also causing prostate cancer. But what is prolactin? Why is it going up as men get older? Well, when men have an erection, when men have an orgasm with an erect penis, what happens is after the orgasm, there's a flood of prolactin and the penis becomes non-erect. That's what prolactin's for. So if you think about that, then taking it away is not a really big deal. In fact, if you look into sex forums about prolactin, they're loving it. To take these drugs called cabergoline, which stop the prolactin, which then allows them to have multiple orgasms, which is thought the reason why women do. and men don't. Anyhow, that's a side note, but I think those are the major issues with prostate cancer going forward. We do want you to be cured, obviously, we want to keep you in a complete remission for the longest period of time. And so for those reasons, we will have you on drugs like dutasteride, also called Avodart, or finasteride, also called Proscar, and it may grow your hair, and that's a good thing. They can have a slight degree of erectile dysfunction themselves, but it's really small. It's, the magnitude of 2%, 3%, something like that. So anyhow, other questions? Yes, Jade.
Can you explain, I mean, how dark and pregnancy for that radiation work there?
So she's asking, how does the DART and brachytherapy work, since those are the two radiation methods that we use at the center, and in contrast to how other agents work. So first of all, again, chemotherapy, we're not big fans of. How does chemotherapy work? Well, what it does is it floods your body with, in essence, a poison, okay? And it just so happens that the cancer folds over more than the normal cells. So you survive it, okay? But that's why with chemotherapy, you're really sick. You're going to have skin chafing, you could have nausea and vomiting and hair loss because it's a toxin flooding your whole body. But it just so happens that since cancers are growing rapidly, it affects the cancer better than the normal tissues. So we don't do that. Around here, we're more interested in targeted therapies. So from that perspective, brachytherapy. I had a lot to do with that a long time ago, the development of it. And it's a really neat way to treat prostate cancer. And what it basically does, the prostate, and it looks something like this, where the top is bigger and the bottom is smaller. We call the top the base, we call the bottom the apex. And it's segued into a right and left side. Most cancers begin along the edge, and you've probably all heard me talk about this. So I used to actually do the removal of prostate with a surgical scalpel, but I found that had an awful lot of unwanted and lasting side effects, especially leakage of urine, incontinence. Big problem. It's a lifelong problem. And the reason that is because when you remove the prostate surgically, you have to remove the internal sphincter of the bladder, which sits around here. And that internal sphincter of your bladder has been working for you your entire life to control your urine. But that's got to go when the prostate is surgically removed. Similarly, the prostate being removed, as I just told you, it's a sexual organ. So the prostate does a lot of things that have to do with sex, including the fact that it makes most of the ejaculate, which we call seminal fluid. And it gets stored actually in these appendages above the prostate here. And so the prostate's instrumental in making the ejaculate, creating the ejaculate. And then it also has a lot to do with the male orgasm, at which time the prostate contracts and it actually pulls the fluid out of these appendages called seminal vesicles. So after recognizing with surgery several things, number one, side effects, incontinence, urinary leakage, wearing of pads and diapers and things like that. Sexual dysfunction, almost everyone gets that in a big way. And it's hard to recover because even men with sexual function after radical prostatectomy, they may opt to have like a penile implant so that now they can get an erection. And there's a little balloon that's inflated in the penis. And that could work only for them to find they have a very difficult time getting an orgasm because the prostate's gone. But anyhow, those are a couple of reasons why I got away from surgery. But the first thing that I did after that was the development of something called brachytherapy. And brachytherapy is a very precise version of radiation. To this day, it's still the most precise way of delivering radiation that we're aware of. There are different types of ways of doing it. One is by putting these tiny little radioactive pellets directly into the prostate gland and leaving them. And that's the one I favor. I've done them every which way. There's another way called temporary seed implants where you kind of put these rods into the prostate, and then through the rods, there's a little, it's kind of a robot that allows the radiation to go into the prostate and then pulls it out after the job is done. I don't favor that. But with brachytherapy, what you're really doing is trying to go right to the tumor and putting these little dots around the prostate. And that's basically what you do. Now, with combined treatment, where we use the DART, which is a very, very precise version of external beam radiation, at first you treat the prostate to a microscopic dose because there's going to be cancer cells elsewhere in the gland happening or which have happened, and that'll help microscopic disease. But for macroscopic disease you can feel, that you can see with imaging that are there, you basically use the brachytherapy to boost those little and sometimes large nodules with prostate brachytherapy, and it's very effective in terms of local control, controlling the tumor where it is. At first, I was just doing prostate brachytherapy, and I had the biggest series in the world, both in New York City and here, and I published a lot. You'll see it on those walls there, publications throughout the years, and there are many more. And I thought it was the greatest thing since sliced bread when I first developed it. And the reason being is that, again, coming out of the rank and file of surgery with all its complications, when I did brachytherapy, we'd never have to utter a word of incontinence, could maximally preserve sexual function. So it really had it all going for it. However, as time went on and I was doing prostate brachytherapy alone, which we call monotherapy, what I started to see was failures associated with that treatment as well. And I had already identified that with radical prostatectomy, that there was a high failure rate, but I didn't expect that with prostate brachytherapy. And it was then that I came to find that the big issue with prostate cancer is an issue that is countered with other cancers differently. Most cancers, and this could be a lump, a bump, a nodule, it could be something we see on a CAT scan or an MRI or ultrasound, and we know that it has these described borders. However, if you really look under it with a microscope, you find that there's cancer cells doing this. That's what cancers do. They grow faster than normal tissue, and they like to infiltrate the surrounding tissues. And so typically, when a cancer surgery is done, what you try to do is remove not only this lump that you see or feel, but take a big swath around it and hope that you get it out. In many cases, it could be really close, and you could leave a cell behind, and it's only one cell left behind that comes back to haunt you with a recurrence. That's a big deal with cancer operations. With surgery, though, the prostate, it's troubling because I came to find that the prostate has no capsule. So you have to think of these tumors here, and they're doing the same thing. They're sending their feelers out, but this edge doesn't act as a good barrier for prostate cancer, and it really doesn't. And so most prostate cancers leak out into the tissues around them. It's really, really popular. It loves to get out of the prostate, and that's an important aspect with every type of treatment for prostate cancer. If you just think about it, surgical extraction of the prostate, well, you can't take a big swath around it to get it all out like you can this tumor here. You can't do that with the prostate because there's too many critical structures around it. You have nerves, arteries, and veins. You got your bladder and rectum, and there's just too much going on. You have the diaphragm below it, and there's just too much going on. So what you do is you peel it off. But if you think about this, if you're peeling this off, you're also leaving those cancer cells that you can't see, and you know they're there. And another thing that happens with radical prostatectomy is because it's a fairly bloody operation, those same cancer cells spread into the tissues and then into the bloodborne areas of your body, leading to things like liver spread, bone spread, lung spread. Those are big deals. There was a recent article only 4 to 5 weeks ago in the Journal of Clinical Oncology, and it was looking at radiation versus surgery for prostate cancer. And they're roughly similar. Maybe the radiation was slightly better, but what they found is that the failure patterns were different. And that was with surgery, there was a much higher rate of failure distantly in liver, lung, bones compared to the patients treated with radiation. Now, what we do in this situation is when I do a seed implant, I try to get to these tentacles or fronds or roots of the cancer by putting some seeds just outside the prostate, and I can do that. And I developed a technique for doing that. And the reason why I can do that has a lot to do with the shape of our seeds. If we were to take a tiny seed, and they're really tiny, they're like smaller than in width of a lead pencil, and they're tiny, about a millimeter or less. But if you blew them up 10,000 times, a seed looks something like this with these very concave ends. And I developed a tool that fits right in the middle of that, and I spin it, and what happens is the tissue grabs it. So that's the reason why when I place seeds in the prostate, they don't go someplace. It was interesting because when I first published on this a long time ago about the placing of seeds outside the prostate, I got a lot of calls from doctors saying, whoa, wait a minute, I'm doing this, but those seeds are going all over the place. They're meandering around the pelvis, they're heading off to the lungs. And the reason why I came to find is that they were using seeds which have concave ends. So instead of this being a cave like that, seed was more bullet shaped. And so it could meander around. And that was the reason why. And that's the reason why I don't use those specific isotopes that can move around. So instead I use the concave. Now, again, a long time ago, I realized that there was also another problem with prostate cancer having to do with the structures around the prostate. So here's, again, we'll just draw it a little smaller here. So here's the prostate, and the cancers I showed you leak out, but they classically go to these structures around them that we call lymph nodes, and they're really close to the prostate. And they go all the way up the pelvis. In fact, lymph nodes start in our toes, and they go up. They're always going up. They end up going into the subclavian artery here and vein. The only place they go down actually is from the neck down, but most of them are all traveling in an upward fashion. And so the cancers tend to migrate to these lymph nodes early on. We were involved with, so I mentioned PSMA PET scans for imaging prostate cancer specifically, but before the PSMA PET scans, we were doing a trial with nanoparticles. We called it USPIO, ultra small superparamagnetic ferrous oxide nanoparticles. We were working with a brilliant doctor at Harvard, University of California, San Francisco, and a doctor in the Netherlands. And we identified that to be by far the best imaging that ever existed for prostate cancer. And it really highlighted just how common it was for prostate cancer to affect the lymph nodes surrounding it. So when I found that out, and I realized that by doing the brachytherapy and just addressing the prostate alone was insufficient, I knew that I have to treat the outskirts. And, but you know, when you come out of, again, the rank and file of doing surgery or just removing the prostate right there, when you're putting the seeds right into the prostate right there, well, the concept of delivering external beam radiation didn't sound so good, because in first glance, I said, well, gee, if I'm shooting a solid beam through the pelvic area to hit the prostate, why wouldn't it not hit the rectum and the bladder and all the critical structures down them? And that's true. And that was the case. It wasn't that long ago that radiation was fairly harsh. I was at this giant hospital in New York. It's called Memorial Sloan Kettering Cancer Center. And I had joined up with some brilliant physicists and some giant tech companies there. They're a research hospital. And they, along with me, but mostly they, came up with a newer type of radiation, which was computerized. And it was called IMRT, intensity modulated radiation therapy. And that was novel. And I did take the team from New York and brought them to Florida here. And this is where, you know, it became known, this newer type of radiation. And I was also one of the first to combine that type of radiation with seeds or brachytherapy, because I was doing a lot of brachytherapy. So those kind of went hand in hand. But through the years, the initial years of delivering this IMRT radiation, I did see an upclick in terms of cure, and that was because I was treating the lymph nodes and the prostate, and maybe some areas just outside the prostate, right and left of the gland where it tends to escape. But I was also seeing more and more bladder and rectal irritative symptoms, and I didn't quite know why, because when a patient tells you that, and you go back to the plan, And you say, well, gee, I'm avoiding the bladder, I'm avoiding the rectum 100%. Why are they having this on the computer? It looks perfect. And it might be. But we came to find the reason for that was because of motion. So what happens is, and for those of you who have been treated here, we all in radiation do the very same thing the first day, and that's a planning or mapping session. And with the planning or mapping session, which takes about 30 minutes to an hour, we put all the information that we have about you into the computer. And that could be the location of the prostate, its proximity to the rectum behind it, its relationship to the bladder above it, and all the nerves around it, and where the bony architecture is, and where the lymph nodes live. All that information is put into the computer. And that is attempted to be done at all other institutions, whether they're using protons, neutrons, photons, electrons, it doesn't matter. That first day planning is still really important. However, that plan gets executed when you finally come in for your treatment. If it's day 1, if it's day 25 or 30, that same plan is being executed each and every day. The problem with that is that, sure, the plan is being executed from the way you were on that very first day, but are all your tissues in the same place each and every day? And they're not. They're all over the place. There's even anatomical changes. For example, many of you treated here know that your prostate cancer typically shrinks down with DART and with seeding and with hormones. And so things change even that. From that perspective, the relationship to the bladder and the rectum, the nerves, arteries, and veins going around here, and this external sphincter here. It's all important. So what we started doing is using imaging-guided technologies, which tracks your body while you're being treated. So now we're not only treating you on a daily basis, but we're imaging you on a daily basis, making sure that everything is lined up. And if it's not, we have ways of changing that. And that's what we call DART. And it stands for Dynamic Adaptive Radiation Therapy. And it basically means that we're now dynamically adjusting your microbeams to your body's motion in real time. And we no longer shoot solid beams. Now we use thousands of microbeamlets to hit the targets. It's very advanced. And with that, I came to find, and we launched that in 2016, that the side effect profile dropped dramatically with that. Sure, there's still some patients who have bladder and rectal irritation, but it's not because it's being hit by the radiation. It's just that radiation byproduct initially is a temporary inflammation, and it may share that with the areas around it, like the bladder and the rectum. So that is the reasons why, not because we're directly hitting those areas. So typically patients treated here, if they do have side effects, they go away over time, just because the inflammation dies down. So that is the principle behind DART and brachytherapy. Now in select patients, I use DART alone. And it's a very good therapy. We think that the benefit of brachytherapy, at least one of its chief benefits, is that you can give this higher dose, directly to a tumor. This tumor get a higher dose because you're putting seeds in it and around it. But it might just be a dose escalation phenomenon. Whereas with DARTs, since it is so precise, we can also precisely target those tumors. And so again, those of you who get DART alone, you know that we do a prostate boost at the end, and that's what we're doing. We're basically boosting these select areas in the prostate as we would have with brachytherapy. Now, is it as good? I don't know. It's a new concept of getting these really, really high doses with DART. It appears that it's safe, but I have a lot of data with respect to the combined modality regimen, combining DART and brachytherapy. And in the old days, IMRT and brachytherapy. I have, decades of data on that. And when I did do that in the past, the combined modality regimen always beat out radiation alone. Now, does that mean DART alone? I don't know the answer to that. In the future, we'll know. But right now, I still tend to favor that approach, combining the approach, just because I do have a lot of data on it. And it's very, very rare to have a local recurrence in the prostate with a combined modality regimen. There's a North American multi-institutional trial right now, and it's called the Ascend RT trial, and they're looking at combined modality regimen and comparing it to either or brachytherapy alone or radiation alone, and they are finding that the combined modality regimen is better. It's 15 to 25% better in that study, and it's a well-run study. Are they getting to the higher doses that I can with DART? Probably not, but anyhow, so right now, in my mind at least, the gold standard is still combining the DART with brachytherapy, but there are patients who I think are good, excellent candidates for the DART alone, and it's certainly better than, again, brachytherapy alone or DART, no, I'm sorry, IMRT to a lower dose. Now, you've all heard about hormones, and I've mentioned them earlier, how hormones can be beneficial for prostate cancer, and why we use them is for many reasons. There's been a lot of data with hormones and radiation. In fact, they were trials a long time ago. They were called the ERTC trials in Europe, and they just happened to combine. They were looking at hormones for treatment of prostate cancer, and they just happened to combine in a few studies where patients got radiation and they also got the hormones. It was by a mistake, but they found those patients did better than everybody else. And so they called them out. They said, what was special about these guys? Why is their treatment so effective? And they came to find, oh, well, those guys just happened to have gotten both the radiation and hormones. And that set the landscape for the use of hormones with prostate cancer. Now, there's many reasons why hormones could benefit a patient having prostate cancer, and there's many theories as well. One of them is that, sure, the radiation takes down prostate cancer cells in a really good way, but what if the hormones also take down a fair amount of the cancer cells, of the volume? Maybe there's less volume left over and the radiation has less work to do. And that's an important theory. Another theory has to do with the cell cycle. So we know that radiation works best in certain phases in the growth cycle of cells. And it appears that the hormones also position the cancer in a more vulnerable stage of the growth cycle for radiation hit. So it's like the radiation just works better because it's hitting the cancer cell when it's more vulnerable. The third, and now becoming a very popular rationale for why hormones work so well, have to do with the fact that, again, hormones don't drop your immune system. They upregulate the immune system. They make it really strong. And so that's an important aspect, because if it's doing that, and the radiation, many of you may have seen some articles that I've written about radiation, also makes the immune system stronger. If you get them together, there's quite a big burst of the immune system. We call it a peak or a spike, and we look to take advantage of that. So these are some of the rationales for combining the radiation with the hormonal agents, and more too. We're looking into something called immunotherapies. And I mentioned earlier in the beginning about a drug called Provenge, which was sent out and comes back. But there's also some other things that we look at in all of you and are treated here. And it's called molecular profiling. And this is a whole new area in cancer medicine, not only for the prostate, but prostate's important. And what we're doing is we're looking at specific mutations that you may harbor in your body. Now, one group of mutations are called germline. So what is germline? Think of germline as familial. That means that you happen to have some reason to getting prostate cancer because your family had these specific mutations. They're often called BRCA1 and BRCA2 mutations. There's others too, CHEK and ATM, and there's a newer one. But the fact of the matter is it might just be that you have a higher probability of developing prostate cancer than someone else because your genome predicted for it. That having been said, if you happen to have that genetic mutation, then it becomes important to notify your family members, because they're probably also going to harbor that genetic mutation and they may be at higher risk. So patients who have prostate cancer also have a higher risk by virtue of those genetic mutations of having increased rates of colorectal cancer, pancreatic cancer, and melanoma. In women, breast cancer and ovarian cancer. And, for any of you who've spoken to me on the phone, I'll ask you all those questions. Do you have any family members with this or that? And the reason I'm asking is to find out if you may be the guy who has a familial tendency to develop prostate cancer. That's what we call germline testing. There's another group of testing that we do, and it's called somatic mutation testing. And what that means is it's not having anything to do with your familial tendency. It's having specifically to do with the cancer. So the cancer that you developed may have a certain mutation that's picked up, having nothing to do with your genetics, but it has all to do with the cancer itself. And we now have agents that we can target those areas, those types of cancers. And we use these agents called PARP inhibitors. There's others that we call formal immunotherapies. And they're very important now in our armory of treatments for prostate cancer. And just about everyone will get those tests. There's a recent company, it's called Foundation One. In fact, the rep was in here yesterday, and they're doing both, which is great because if they can do both under one ceiling, then insurance pays for it all. So you get to know whether you have a genetic, predisposition or whether it's the mutation itself. With genetics, that never changes. So, if you have a genetic predisposition at 5, when you're treated at 5 years, if we checked it, you still got it. At 10 years, you still got it. You're always going to have that. The somatic mutations, which is what the cancer is doing, that can change. And in fact, we're doing studies now demonstrating that patients who've had no mutations and we couldn't target them, 2 years later, they have some mutations that we can target. The cancer has changed its face. And so the face that it's changed to is now something that we could target. And we're really all about targeting therapies. We don't like the deluge of cancer therapies, going throughout your body, like I mentioned earlier with chemotherapy. Mind you, there is a role for chemotherapy. There have been studies, and the studies do demonstrate that a specific agent called toxitaxel has anti-prostate cancer effects, and most chemotherapy doctors use that for patients. However, as I say, there's an awful lot of other treatments available for prostate cancer patients, and they typically don't select that chemotherapy regimen unless it's the last thing they got. But as we're seeing with prostate cancer, the longer you live, the longer you're going to live because it just keeps coming out with newer and newer therapies. And, it's almost every 6 months, there's another breakthrough with prostate cancer, and that's really great. And with other cancers as well. I just spoke to a gentleman who had pancreatic cancer diagnosis. He was here and I saw something on his scan and he was evaluated and unfortunately has pancreatic cancer. However, his pancreatic cancer was associated with a select mutation, which can be targeted with immunotherapies, and he'll do very well. There were some lung cancer discoveries. It's a special gene called the ALK rearrangement gene, and it was found that that particular lung cancer would have a median survival of 6 months, now has a median survival of 7 years. And that's because it had a select mutation. I think that's the direction cancer medicine is going, looking more and more for mutations that are unique to the cancer and that we can target. So those are the reasons why we use DART. That's the reason why we use brachytherapy, and that's the reason why we use hormones. And with every patient, I try to figure out, and it's kind of from experience, if I'm going to use hormones. And by the way, not everyone is a candidate for hormones or needs hormones. I'm not a hormone bug, and whenever it's not necessary, I tell you don't get it because hormones have side effects, and I just don't like that, anything that has side effects. But when there's a need, when I find there is a benefit, then I have to at least tell you this is a potential option and it could benefit you, for the reasons I've discussed. But then it comes down to, well, how long do I have to be on these hormones? And again, everybody's different there, and I have to really get a feel for your cancer to figure that out. There were studies looking at radiation and when the hormones were given. In some patients just before, in some patients just during, in some patients just after. Then others got before and during and after. Well, it turns out that the most beneficial studies identified that the patients getting during did the very best. And then if they got it before and during and after, it was still advantageous, but at least during, if you're going to get them, if you don't want to get the side effects of hormones, which does come with side effects, the hot flashes, which could be devastating here in Florida, could have some degree of fatigue. You could even get some breast tenderness. Those are the major events. Some people get some mood changes, but those are pretty much the major ones. But if you're going to get it, if you want to get it but don't want to be on it forever, then choose the during period of time, and that's typically when the radiation starts, and maybe for 4 to 6 months, something like that. But some patients, I do use it for a couple of years, and some patients we have to use it in an on and off way for the rest of their lives. But listen, if that's what's going to keep a patient complete remission, then that's something. We don't cure diabetes, we don't cure typically high blood pressure, but we control them. And so we can control the cancer too. That's obviously very important. And we're very good about that, controlling cancers for a lifetime in those patients who have widespread disease. Yes, sir.
Why do some patients have more aggressive cancer than others?
So he's asking, why are patients having aggressive cancers while others have low-grade cancers? And interestingly, there's over the past since 2009, we're seeing a real fast uptick in aggressive prostate cancers. Back in 2008, 2009, this task force, this preventative task force in the United States, decreed that if you're age 75 or greater, you don't need to be tested with a PSA. And in fact, told all the doctors, you don't have to get PSA for any age. What that did was it removed any liability, because up until then, there would be patients saying, why didn't he ever check my PSA? And now it's 10, it's 20, 30, and it's spread. Shouldn't he have done it? Back then, it was a concern for them. Now it's not a concern at all, because the guidelines say you don't have to be tested at all. But what's become of that is patients having had prostate cancer for a longer time, and their PSAs get higher, but more importantly, the cancers become more aggressive. Cancers only become more aggressive. They never go the other way. So, I've mentioned some things that you can do with diet to, kind of keep it in check and hopefully have some anti-cancer properties, but it won't get rid of the cancer. It just doesn't go away. But what they do is that when they hang around, they mutate. And when they mutate, they always become more aggressive. So a Gleason 6 always becomes a 7, becomes an 8, becomes a 9, becomes a 10. We all heard about, the President Biden, he's got an aggressive Gleason 9 tumor, and he kind of falls right into that group of people following the NCCN guidelines. You don't have to check a PSA. It was only after he was found to have a nodule and urinary symptoms that they checked. And of course, he's got more aggressive cancer. So it's probably been around for a while, but now it's a Gleason 9 and it's spread to bones because it's been time. There's time has gone by. And so that's the reason probably the most patients, because back in time, I've done thousands of prostate biopsies, and going back in time, the majority had Gleason 6, maybe 7, 3 plus 4. Now more people have 7, 4 plus 3, 8s, 9s, 10s. It's just the way it is. Unless it's a disease pattern that's happening independent of that. Also, with prostate cancer, for example, I follow men with prostate cancer. It's called active surveillance, where I identify you have a cancer, but it's very small and it's very low grade. We know where it is, we'll track it. And some men want to do that, just track it and don't be treated. And what I expect is that in that patient, since it's a low-grade tumor, the low-grade tumor, if this is 0 and now it's at 5, I expect the curve to go something like that upwards. And that's the typical trend of a low-grade prostate cancer. However, if that curve starts going down and your PSA 5 starts becoming 4.5, 4, 3.5, what it means is that the cancer is actually mutating to become something far more aggressive, and it doesn't resemble the prostate cell anymore. Prostate cancers, by and large, resemble the prostate cell that they began from. The normal prostate cell also makes PSA. That's why men who have enlarged prostate, called BPH, it's more volume of prostate tissue, the PSA can be higher. However, if it becomes a cancer and it becomes a low-grade cancer, it's growing faster now. It resembles its parent cell, so it makes PSA in a little more prolific way. However, once it starts becoming more aggressive, it starts losing its face of the prostate entirely. And by the time you get to an 8, 9, or 10, it's hardly making any PSA at all. And, you know, I often treat people, men who have prostate cancer, and their PSAs are like 0.8, 1.0 from the get-go. And that just means they have very aggressive prostate cancers. Okay, well, if there are no other questions, we'll conclude the Prostate Cafe. Yes, sir.
Mike is asking, he said he was treated here 8 years ago, and back then his testosterone level was relatively low. Now, 8 years later, it's returned to normal levels. He still has an undetectable PSA, but he wants to know if he should be concerned.
Not at all.
Not at all. Okay.
Not at all.
Okay.
No, you don't have to be concerned with a normal recovering testosterone after formal treatment. It takes a lot more to stimulate prostate cancer because it's not even there anymore. All right. Thank you.
Thank you.